Mustafa and Ken here. Welcome back to the Alert Medic 1 podcast.
Alert Medic 1 response.
Hey, why don't you introduce yourself to us first?
Cody Patrick. I'm a paramedic here in Hartford County. I've been a paramedic for going on 10 years, and I've been a paramedic at quite a few places, honestly.
Yeah, so I'll tell you what. In my career, I've only done a conscious IO once. And again, it was a lady who's, her fistula for dialysis had burst. And it was actually the last call of the very long night shift. And it just clicked that was the appropriate thing because her pressure was like nothing, and she her was not mentating, and we were transporting. We had a tourniquet on as high as we could because that's the only way we get the bleeding to stop. And I got a similar reaction from the hospital that I took it to. So and I imagine it's kind of hard for EMS who does not do things like this and maybe get a little bit of rough feedback from the hospital that they're transporting to. So yeah, I mean, I'll hand it off to you guys. Ken, Dr. Vipper, what do you guys think?
Sometimes you got to do what you got to do, right? And I think that, Cody, correct me if I'm wrong. I think my observation over the last 10 years in particular is that EMS is actually teaching the EDs how to do some things better. We were using IOs before I saw any ER use IOs, and IO is a lifesaver. And yeah, the patient you described, in extremis respiratory distress, sounds like she was, almost begging to be intubated. You don't have IV access. You can't treat this lady. So you got to do what you got to do. I think that we were doing it long before the EDs, and then they saw EMS doing it, and they said, oh, wait a minute, you can do that? And then, same thing with video laryngoscopy. I found a lot of jurisdictions put that out, and then the ED said, oh, yeah, that might be a better way to do things. But I hear you about the pain issue with regard to IOs. We're classically taught that the drill part isn't so much the pain, it's the gnawing pain of the marrow cavity being expanded by the initial, forceful flush that we give to open the marrow space to allow for drug delivery. And then for each medication or bolus that we give, the potential for that gnawing kind of deep-seated pain as the marrow cavity is expanded. So I do agree, it's nice to give a patient like this some analgesics. But I also think about something I learned when I was training at shock trauma. There was one attending physician that used to tell us, and this may not be politically correct, but he would say when patients would come in extremis, usually with penetrating trauma, depressed mental status, that the patients had to deserve their analgesia. They had to give you vital signs. They had to give you reassurance that they could tolerate the analgesia. So, I'm not sure I wholly agree with that mindset. I think I'm going more of like a compassionate provider where I want to treat people's pain. But I definitely think it has to be balanced against what are the priorities. Sometimes we have to save the life or correct the major hemodynamic abnormality before we consider kind of second line things like analgesia. But interesting.
Yeah, I think we're in a little bit of a culture shift in a few areas of EMS, two of which we're touching on right now. Number one, with conscious IOs, when I went through paramedic school about 15 years ago, we were really only doing IOs primarily in kids. We were starting to talk about them in adults, but not really so much the conscious. We didn't even have the easy IO at that time, at least not that I'm aware of. So I think now with students being taught to be more aggressive about these procedures, painful procedure in general, I think that we're seeing them more. I'm definitely seeing them more in the field. And as just kind of a side note, I'm curious if your experiences with the pain of getting the IO, because when I've seen that done on a conscious person, it definitely seems pretty painful. And I understand the whole idea that, the pushing the fluid in the medication is more painful. I'm not disputing that. I've just noticed it definitely seems to hurt when people get IOs when they're conscious. And the other thing is that I think one of the big culture shifts we're seeing right now is with pain management. Pain management is something that was not. I remember being taught it's one of the most underutilized skills in EMS, and I think it still is. But I also think we're seeing it done a whole lot more. Um, I know. I mean, I personally have always tried to be pretty liberal with my pain management, but I've noticed too. I'm giving out. As a supervisor at work, we carry a lot of these drugs to restock units. I notice I'm giving out a lot more fentanyl and ketamine. So I think we're moving in a positive direction with both of those topics.
Yeah, I would say so. The what's interesting, bringing it back to your IO, the first thing that I think of when I think of pain management for intraosseous infusion is the lidocaine, and how, I'll be honest with you, I didn't know how to appropriately do it until I was taught by the representative of the manufacturer of EasyIO. I attended a class, and the procedure is actually, you're supposed to load what is it, 4% or 2%, into a J loop, preload it, right, and then you do a slow and push, and then you're supposed to let it sit for a few minutes. I can tell you what the amount of time is, and then you're supposed to push more in and let it sit. Now, in an acutely crashing patient, you can't really do that, right? In my experience, I've seen EMS inappropriately utilize lidocaine and essentially turn it into just a push, right? They just push some lidocaine through, and then don't allow it to work. Which, I mean, they shouldn't, because their patient's dying. That's part of the reason they're doing it. So I guess that would be a question for you guys as well. Is there an appropriate maybe adjunct to assist with pain that's not lidocaine? And also, are there situations where EMS should be utilizing intraosseous infusion where there would be utility in using the lidocaine first? So I'll open it up to you guys.
I think that, if you're talking about traditionally, if we're doing an IO on a conscious patient, the patient is crashing. So maybe sometimes even holding off until you get the target medication in, and then going back to address it is maybe an option. If you're not going to preload it, maybe. Or if you are preloading, maybe you got to do what you got to do, because we're not really, we're only giving you the IO for pain meds. No, we need to give you epi, mag, or something that's going to save your life immediately. So sometimes I guess we don't have time to let the lidocaine work in the first place.
Yeah.
I wonder if there's a good bridge there to get to that point, other than maybe push it back and just get the first line med in real fast, or with the proper time, whatever you need to do.
Yeah, I mean, I think it would be kind of like any procedure, where, for example, cardioversion. Do I have time to give you some midazolam to kind of blunt this procedure I'm about to do, or is your pressure 60/30 and your heart rate's 220 and we need to light you up right now? I don't like the idea of doing painful procedures without any kind of analgesia. But there does come a point where it's a question of, I guess, saving the life over not. Then again, there's also the old adage of an IV's never saved anybody's life. So whether or not that's true, I don't know. But yeah, I don't know. That's just kind of my take on it. I'd love to hear Dr. Wittberg's.
So, yeah, I agree. Going back to Moose, your comment about the administration of lidocaine through an IO, you usually want it to kind of percolate and kind of get absorbed slowly into the marrow space before you rapidly expand the marrow space. The easy IO reps will use the saying, no flush, no flow, when they teach you how to use it. You really do need to forcefully flush an IO to open up the marrow space. And again, it creates this deep, deep, deep gnawing pain. So if you can load your J loop with preload it with 2% Lido, kind of instill that very slowly, about 20 mLs, and then give another 20 mLs a few minutes later. It's just not practical in a patient that's crashing and burning. So sometimes we have to, in essence, utilize the patient's pain and their physiologic response to pain to keep them alive, to stimulate them, if you will, as we do other higher priority tasks. One of the things that I was thinking about is I've become obsessed lately with watching Amazon Prime helicopter EMS shows that are filmed over the pond in England, where they staff these air units with physicians and paramedics. And do you guys know what you see? You know what they do as soon as they roll up to like a motor vehicle crash and they're cutting somebody out?
Give him pain medicine.
What's that?
Give him pain medicine.
Yes, they do. Do you know how to give him pain medicine? And it would have. The reason I bring this up is I think it would have worked in Cody's case.
Is it IO or intranasal? Probably intranasal.
No, it's inhaled nitrous oxide. They give him like the albuterol puffer, the peace pipe, and they just say, "Hey, take some nice deep breaths," and they give him inhaled analgesia. So that's something we don't use in the U.S. and I kind of have recently questioned why. And as I've read about it a little bit, I've read a little bit about the potential for abuse, the ability to scavenge it when it kind of gets into the back of the medic unit and not intoxicate the people that are providing care. But if you look at how it's used across the pond, it's often used out in on the scene where you're not in a confined space. The other thing I thought about with regard to the comments that Cody made and Ken made was, there are other routes to give analgesics. You can give intranasal analgesia. Fentanyl can be given intranasally. I do think there has been a paradigm shift. I think there's been a lot more focus on pain assessment and management, but that's been here for a while. And people say that, what is it, the fifth vital sign, right? Is it the fifth vital sign? That's also, contributed to the emergence and perpetuation of our opioid epidemic, this obsession with assessment of pain and treatment of pain. I do believe that pain is potentially a protective mechanism and can give you sympathetic stimulation. And in Cody's case that he presented, may have helped patient continue to breathe, although it wasn't may have continued to give her that sympathetic drive that just allowed her to get to the hospital and for you to do the things you needed to do to get her to the hospital. And that we have to balance a lot of things. We have to balance the need for that, pain response and protective pain response and kind of sympathetic stimulation that comes with the pain response against, other treatment priorities and other factors that we as kind of, especially, those of us that are charged with running a scene, paramedics, the higher level care providers, supervisors like Ken, you gotta weigh a lot of things. What is your transport time? How are you getting to where you need to go? Are you waiting for a helicopter to land, and are you tacking on additional time? There's a lot of I think things that you have to weigh as you decide, what are your treatment priorities and where in the sequence do you start to give analgesia, if you give it at all. Did I answer your question?
Yeah, man. Of course. Oh, wait. I thought he said, can I ask you a question? But he said, did it answer your question?
Yes, he answered your question.
Hey, I have a question. What do you guys think was the effect on EMS administration of pain management from the opioid epidemic, specifically from the negative experiences, burnout, other things that folks had, during the height of the opiate epidemic?
I think we got ketamine and Toradol out of it.
Yeah, I haven't honestly noticed a whole lot. It didn't change how I gave anything, and I always offer the patients, do you want this? Do you want fentanyl? I've never had anybody tell me no. If they're really in severe pain, I haven't seen it change anything from the patient's angle, and I have not noticed any change in how much we give out at work or how much I personally give out. I think when you're talking about in the acute pre-hospital setting, what we're doing isn't really perpetuating the opioid epidemic, in my opinion. Now, if I had the ability to send the patient home with a 30-day prescription of Percocets, that may be an issue there. But of course, that's not what we do in EMS. I think that's more of an issue that we see from the hospital or from the primary care or the pain management doctor. But that's my 2 cents.
I think
there's been probably a bit of an irrational fear amongst us that work in the field that, oh my God, if I give this patient whose femur looks like this and is poking through the skin 50 micrograms of fentanyl, I may be responsible for them, chewing on oxycodone and MS-Contin, a couple months downstream, and all the bad things, the dominoes that fall as a person becomes addicted to opioids. My philosophy, the way I was taught through my residency and my philosophy practicing in emergency medicine and critical care is it actually doesn't really matter what your lifestyle is before I met you, what drugs you took before I met you. If you are in pain and you are suffering, I have an obligation to help alleviate that suffering acutely as I begin to assess you and order tests and stabilize you. So my over under on the link between kind of EMS and addiction and our opioid crisis is that it has instilled this unhealthy fear of us treating pain in the field, and particularly treating it, I'm going to use the word aggressively, kind of putting it towards the top of what we do. I think there are a lot of other EMS physicians that I know that kind of come out and de-emphasize the pain management portions of our protocol because they come up with a list of reasons. Oh, short transport times. Even what I was talking about before, the protective effects of kind of stimulation from pain. They'll get to it at the hospital. We have other treatment priorities. The onset of action of some of these things, particularly if we're going to talk about Tylenol, really don't affect the treatment of our patient while we have them in the field. But that's my concern is that we may not be treating people who deserve to have their pain treated.
I think that's fair. I think I've seen that with like other providers. I also see like lately, a lot of the patients I'm running to, we're saying, hey, we can give you this medicine called fentanyl, and they're like, oh, I don't want that. That's what's killing people on the streets. And you gotta like talk about it, like, no, it is, but it's not that same thing on the street. And then you gotta like offer them the Toradol or the ketamine if appropriate. And then they're maybe a little more open to that. But I think there is some fear with like at least the patient population I'm seeing with actually the fear of fentanyl itself right now currently. And providers are still on top of having patients who are scared of fentanyl, like, oh, all right, they don't want it, I don't have to offer them anything else kind of thing. And just kind of neglecting the patient's pain and not offering them other things because there's the fear of getting the wrong ketamine dosage because we carry 2 to 3 different vials of ketamine and you might have to dilute it down. And somebody's like, oh, I'm going to give the wrong concentration and really mess this person up kind of thing. And then it just all kind of becomes like a cop-out, it seems like. Like, oh, the patient's scared of fentanyl, don't have to do it.
Yeah, I 100% agree with you and kind of with Dr. Vipper. No, I do agree with Dr. Vipper. So what I would say is, in my anecdotal experience, especially when I was more in the field, and I feel like that was like the height of the opioid epidemic. There was, I don't think stigma is the right word. I think the right word is like. Maybe stigma is the right word, but I was always judicious with my pre-hospital pain management. Why? Because I also saw the same patient wait in the hallway for 30 minutes for a bed, which is even more. I mean, and again, that's not a shot at hospitals. That's just the system we work in. The once the patient gets to the hospital, they're going to have to get triaged and registered, triaged, assessed. Then they get pain management. Why would we not give them something to take the edge off before they, before they even roll into the hospital? But what I've seen is folks say, "Oh, you're a really nice guy," or "I don't treat pain unless like there's a bone sticking out." And there's so many things in between where, and also I hate to say it, I'm not going to call anyone specific out, but there are some providers that do have a tendency to make judgments off of how the patient presents, with social demographic factors and so on and so forth. Maybe they don't recognize that their decision is anchored in some of that, but I see it, and it's kind of sad, and it's completely inappropriate as a clinician. I guess that's sort of a hot take. What I would say though is, I think that, and of course I have not been in the field and going on 3 years now, right? Actively full time, but don't nod your head, Cody. But it's good to hear that people are more judicious about it. I think there's also a clinician fear on it. For me, I wouldn't call it a fear for me, but I have yet to give ketamine because right when I was, transitioning away from the field, that's when ketamine was brought into our protocol here, and I've yet to give it. So
Moose, can I just chime in here? So
yeah, sure.
there's a good article. It's a little older in pre-hospital emergency care, which is the peer-reviewed journal of the National Association of EMS Physicians. It was written in 2012. The lead author was Dr. David Cohn. He comes from Yale New Haven Medical Center. The title of the article is Paramedic Attitudes Regarding Pre-Hospital Analgesia. And he conducted a study where he basically interviewed 15 paramedics from 5 EMS agencies in New England and identified major themes regarding their attitudes regarding the administration of pre-hospital analgesia. And I just want to read you down this list of 5 things because we've kind of hit on them already. Number 1, a reluctance to administer opioids to patients without significant objective signs. For example, deformity, a bony deformity or severe hypertension. 2, a preoccupation with potential malingering. You kind of hit on that a moment ago with regard to maybe kind of walking in and seeing some socioeconomic cues at the scene and kind of your own bringing in your own personal biases as to whether or not a patient might be malingering or not. 3, ambivalence about the degree of pain control to target or to expect. 4, a fear of masking diagnostic symptoms. I don't think we've talked about that. That usually comes into play when we talk about abdominal pain and kind of masking the ability of another clinician to do a good exam. And the last one, 5, an aversion to aggressive dosing of opioids, kind of just sticking to your protocol and not requesting more if a patient is still having more pain. Those were the 5 themes that he identified in his article in 2012.
I forgot about the whole masking pain thing. But that's
like an old school thing.
When
I first got my paramedic, that was the thing. It's like, you don't give morphine for abdominal pain because you're gonna hurt the assessment. And then my emergency medical director in Cecil County was like, no, you're not going to interfere with us at all. We have ultrasound.
Yeah, interesting. Wow. Hey, let me ask you guys this. So, give me some tips for our listeners for how do you guys assess pain? Like, obviously, well, actually, no, I don't want to anchor any of your guys' answers. So maybe I'll give it to Dr. Vipberg first because I want to see how he does it, and then I'll hand it off to either you guys, both of you guys say it, and then we'll go from there.
So I think there are, a lot of studies and a lot of ways we're taught to assess pain. So you'll often see things like a visual analog scale or a CPOT scale. There are a lot of kind of validated scales that are used to assess pain. I'd have to do a lit search to see what the best pain scale is to use in the pre-hospital realm. And certainly assessment of pain can be stratified. The best way to assess pain has to be stratified by age too, and the patient's ability to communicate, i.e. how do you assess pediatric pain versus adolescent versus adult pain versus geriatric pain? And I don't have that on the tip of my brain right now, but assessment of pain, I think for me, to be honest with you, is multifactorial. It begins with, so every scene begins with, of course, BSI, primary, secondary service. So after we get past all that, and we're in the thick of treating our patients, I look at their vital signs. I look at my physical exam. I talk to them, history. I'm looking at the med list. I am, maybe speaking to bystanders or family members that know the patient. It's a very multifactorial synthesis. I don't think I have a singular way that I assess pain, but at the end of the day, I think it comes down to, your experience. I mean, there's obvious things, when you see a compound femur fracture, obviously the person's going to be having pain, but when the physical exam becomes less revealing, I think that's where it becomes more challenging, and that's where experience is helpful. So the short answer is it's a multifactorial assessment based on my complete physical exam and assessment of the patient, gathering history, gathering some also historical information regarding their medications that they take, the history of the present illness as regards to the chief complaint, also paying attention to what, if any, the patient has taken before I've arrived that might be kicking in. If I'm in the hospital realm, fortunately, I have the access to sometimes have the access to old medical records that I can reference to help me make the decision, much the way you would with kind of looking at an EKG with left bundle branch block and trying to figure out if it was new or old and what you would do with that patient. So very, very multifactorial layers that I peel back, but a decision that I usually make quickly because I don't enjoy seeing people suffer.
Yeah, it's tough, right? Especially in the field, you really have to look at pain as a subjective thing. You know, it's if somebody tells me they're in pain, there's no way for me to prove they're in pain or not in pain. So you really have to couple that with, like Dr. Wittberg said, the things happening around that complaint of pain. If they have a mechanism of injury or nature of illness that support the fact that they're in 9 out of 10 pain, then yeah, I'm probably going to provide some kind of pain management. But if they tell me they're in 10 out of 10 pain and they're sitting there chatting on their cell phone and they're laughing and, sending texts and uploading Facebook Live videos from the stretcher and stuff like that, they're probably not really in desperate need of immediate pain management. But that's still, it's a ethical thing. Um, what right do I have as a paramedic to determine that you're not in pain and I'm not going to treat it? You have to really be able to articulate, in my opinion, why you did or did not provide pain management. So it's a tough call. Multifactorial is a great way to put it.
Yeah, pretty much my opinion is to piggyback on both of you. Um, I described a philosophy of who am I to truly judge what your pain is? I don't know what you've lived through. You might have been a cancer patient when you were a child, or might have had all these other experiences that led you to this like higher pain tolerance that, you're saying you're in pain, but your vital signs aren't showing it, or XYZ thing. I mean, I think Ken's right. If you got time to like play on your phone or something like that, it kind of gives us clues that maybe there's maybe a little exaggeration going on there. But generally, I'm pretty liberal with it. I'm not one to judge somebody else's pain. If you're telling me you're in 10 out of 10 pain, and especially if you're like looking sick, if you're not looking miserable, who am I to really judge what your pain level is? It's all about perception, I think. I think that's what pain partially is it's about perception.
Yeah, so what I agree with all of you guys. What I usually use, I guess usually, I don't know if that's a good thing. What I used to, I don't know. No, the goal is to get back in, but no. So an objective and a subjective metric, right? So subjective, I should say 1 to 10. How bad's your pain? Objective FACES scale, right? That's been pretty useful. And then try to, if there's a lot of variance in that, right? So what will variance mean? Meaning if they say 10 out of 10 pain and then like what you said, if they're on their phone, they're laughing, whatever, maybe I'll hold off. Then if there's more of if they're more synchronized, right? So they say 7 out of 10 pain and then they're clutching, they're very tense, they're upset. Sure. But I always err on the side of caution and give that pain medication because we have to be realistic with where we fall into the chain of medicine, right? So we're on the front end of things. The dose we're giving in the grand scheme of things is probably not going to be that significant compared to their primary care, the relationship they hopefully have with their primary care physician, or oftentimes the relationship they might have with an ED because that's the only healthcare they get. Regardless, that's not our purview, right? We are there to treat the immediate emergency and get them to the appropriate level of care. A question that I have for you guys as well, this is something I've personally experienced. What are some strategies you guys use for folks that are already on pain medications and may not be responsive to the pain medications you have? Well, that's not true for us, but maybe a lot of places don't have Toradol, ketamine. Sickle cell patients have been particularly difficult to care for in my experience because they're on hydromorphone, other heavy hitters. How do you guys address that? Because from my understanding, Toradol kind of goes out of the picture with that, so I'll hand it off to you guys.
I think the biggest thing for me as a paramedic is give them the early opiates on them, opioids, whatever you're carrying these days, and then that's probably not going to work. And you're either going to be a short transport time again, not to use it as a clutch, but how long do you really want to try to get this patient high dose opioids before you get to the hospital where they have bigger, better things than we might carry, But if you're in some place that might be like 45 minutes away, my opinion is you should be probably get on the radio and asking for the doctor for more orders. Like, hey, I got the sickle cell crisis patient. We're coming in. My protocol is not going to be enough. I need some more.
Yeah, so I think the simple answer is that patients that take chronic opioids develop tolerance. They often need higher doses. They often need doses that far exceed most jurisdictional state protocols kind of upper limits. And that's the importance of base station consultation, collaborating with your receiving hospital. There's other things that can be done, though. I think that compassion, reassurance, um, you know, um, there's other non-pharmacologic things that we can do to help alleviate pain that I don't think we often do, or a lot of us don't do. And that's probably another conversation. But um, short answer is higher doses. And what I was going to say is that if you're going to go into the high dose range, you have to be able to deal with the consequences of your actions. So if you are giving higher doses of fentanyl, you should probably be ready to support that person's airway if you overdo it. Same thing with ketamine. You have to be prepared for the consequences of your actions. Every medication, including the medications in our toolbox for pain management, are part poison. We know that very well. So we just have to be ready to deal with the consequences of particularly a depressed respiratory effort, heightened monitoring if continuous waveform and tidal nasal capnography is available, while we aggressively treat the pain.
I don't really have anything to add to what Dr. Wittberg said. You're all looking at me. I mean, it's nice that here in Maryland we have multiple tools in our toolbox. And
Recently have multiple tools.
Yeah.
Yes.
Just recently, yeah.
Good on Maryland for that. Yeah.
But I mean, other than like what Dr. Wittberg said, there's not a lot you can do. I mean, certainly if you're talking about an extremity injury, we can splint. I do think the compassion thing is a big thing, just knowing how to talk to somebody. But beyond that, all you can do is beat feet to the hospital and hope they can get what they need, because unless you go outside of the protocol and request orders for really high doses of medication, there's not a whole lot we can really do.
Hey, Dr. Vipper, can you talk to us a little bit about mixing medications? So, like, say I give one thing and then I want to give another thing. Can you talk to me about that?
I was actually going to ask the same question. Like,
good.
like hitting fentanyl and then maybe going to Toradol or something like that.
Yeah, so absolutely. So this is a strategy that I fully embrace in hospital treatment in the ED and ICU. So the word you guys are looking for is multimodal, the multimodal approach to pain management. I think it's undereducated, is that a word? Undertaught in the pre-hospital paramedic curriculums, but multimodal pain management is a great strategy. One of the premises behind multimodal pain management is by combining medications that work by different mechanisms, target different receptors. You may be able to spare or use less dose of other medications that have adverse side effects. And I'll just give you a typical example. I have a patient come up to my ICU that had a big abdominal surgery, a splinting, but I want to give them good pain management. I want them to kind of remain aware, have a good respiratory effort. They may have gotten a local block in the operating room. Okay, so we don't do blocks in the field, but maybe it's something we should talk about. Maybe it's something our advanced practitioners that are practicing in the EMS realm can do, especially now that we have more widespread use of ultrasound and we can really guide needles to where they need to go. So we might give a block of a lidocaine type medication to anesthetize the person's abdominal wall, or you could imagine kind of a degloving injury where a patient gets their hand caught in a piece of machinery that we respond to, instead of slamming them with opioid as we're saying that 3 times fast, as we're trying to extricate them from that machinery and they're kind of losing their airway. If we could have somebody come in and with ultrasound do a block. Okay, so that would be one kind of mode. Then we give them maybe a gram of Tylenol, and then we give them a little bit of Toradol, and then we give them a little bit of an opioid like fentanyl. So we have multiple medications given by sometimes different routes that target different receptors. and allow us to, in particular, spare the amount of opioid that we have to give to achieve the same reduction in pain level that we would have achieved by just giving one medication like an opioid. So multimodal pain management is great. I don't know that I see it written into a lot of protocols that I've reviewed. I don't know that it's taught in paramedic programs, but if you can give different analgesics that target different mechanisms of action, you'll typically have, a better reduction in pain without some of the adverse side effects. Now the question is, do you have those medications available in your bag? Is the patient able to take those medications by whatever route they can be administered? So if we think about acetaminophen, Tylenol, typically in EMS systems, we only give acetaminophen by mouth, right? In the hospital, we have an IV formulation. So there's, again, as with everything else, there's a lot of kind of multifactorial synthesis that has to go on in making these decisions. But multimodal pain management is clutch when treating patients and trying to preserve their hemodynamics, their airway, reflexes, and so forth.
I think that answered that question pretty well.
Yeah.
So you have tourniquets bolded in your notes, Cody. So
That's because I was using Apple Notes, and it just happened to be the top thing at first.
Oh, okay, fair
But I was
enough.
making a list of painful procedures EMS does that sometimes we may be hesitant to. I think most people understand that tourniquets are pretty. You're gonna have to do it. They're gonna hurt. If it's not hurting, you're not doing it right, or the patient's dead, kind of thing. But there's I made a whole list of just different procedures. Sometimes people are hesitant on. I think some people are sometimes hesitant on cardioversion again because it hurts. Some people, how often do you hear of a conscious needle decompression in the field? Usually it's an unconscious patient again because it hurts, or you're waiting for them to be unconscious kind of thing, or something like a splints hurt. We don't necessarily pre-medicate somebody for splinting. Maybe we should be doing that. And sometimes the splint is the fix to the pain, or pelvic binders, pacing, and even this is an old school thing, but nasal intubation before we had CPAP was a thing, or somebody who can't tolerate CPAP. Nasal intubation is not fun if you're conscious.
Mm-hmm.
So, but those are just a small list of things I had written up that we do these things in EMS that unfortunately they're going to hurt, especially for a little bit until we can get you to where we can make you feel better. And sometimes I think we forget to do the part where, all right, we stabilized you. Now let's make you comfortable, kind of thing.
You see, so and it's interesting. I was reading through your things. I think pain. It's interesting you bring up that there might be opposition to that because of pain. Because I'll tell you what, every time I've made the mistake of not doing an intervention when I should have, it was, looking back at it, it was usually because I'm like, oh crap, this is a pretty big deal.
Yeah.
And I'm gonna do this thing that I don't do often, and I know that there's gonna be a supervisor. No offense, Ken. That's gonna be checking my report as soon as I submit it. And oh man, he might even call the medical director, and the medical director may not exactly be a cool dude or gal. So that's an interesting thing too. I know for a fact. So I had one guy who was in a pretty bad wreck, and he was hypotensive. He was diaphoretic. He was tachycardic. Had been took the majority of a T-bone, but his oxygen saturation was okay. So I was like, this guy doesn't need to be needle decompressed. And we get to the hospital, and I had consulted, and I brought a physician on board. And the first thing that the physician said was, "Why didn't you ask me for needle decompression? That's why I thought you were consulting. I would have given it to you." And I'm like, and at that point, I was like, yeah, why didn't I ask for it? And you start realizing that, oh man, maybe I was just a little
gun shy.
Yeah, which is probably better than being too aggressive, but I don't know where that fits into our pain medication conversation. But
well, I think there's a lot of perception. I think, not to pick on the older providers, I think this comes in a lot of them, is we're teaching our newer paramedics to be more aggressive. And whereas you look maybe 20, 30 years ago, we're teaching paramedics, it was a lot more hesitation with things. And now we're teaching paramedics, to do the conscious IO, for example. That's one of the most painful procedures I think we do maybe out there, is pushing that initial bolus if we're not doing it correctly, especially, So we're teaching people, if we're doing conscious IOs, it's okay to cause some pain to some degree, because sometimes you might have to save somebody's life. Or I think in the past, again, maybe we were a little hesitant to do those things. We were restricting paramedics a little bit more, maybe not by protocol, but just based off education.
Yeah, I mean, one thing that I've seen both as an instructor and a supervisor is when you look at, are things done that are or I guess, are things not done that are not aggressive enough, or are things done that are too aggressive? The vast majority of what I see is things should have been done that weren't done, usually because, one, it's a painful or invasive procedure like a decompression on a conscious person.
So I have this theory. I don't know if and I have to explain this theory before I explain what I'm going to say. So if you take, say what you were saying, Cody, take an EMS clinician that maybe didn't have the most robust education, then they're operating for an entire career, 20 years, or whatever amount of time, where they maybe were a little bit aggressive within reason, but when they saw adverse effects to their interventions, they couldn't explain why. Right, because they weren't taught that deeper under that physiology. They don't understand why, giving cardizem to the person who just got prescribed beta blockers and now they just put the patient on heart block. They don't understand that, right? They don't understand the baseline stuff. So when you don't understand a particular situation and you see a negative outcome, in my opinion, I don't know if this is right or wrong, I think that you will err on the side of caution, and events like that over the span of a career make a super conservative clinician. And it's not really their fault. It's the system that didn't provide initial education and then supportive education